This is the No Stroke Podcast with your co-hosts David Dansereau and Michael Garrow, helping you to support and thrive in life after stroke. Their podcast is designed for educational and community support purposes only and should not replace medical treatment and guidance of your own health professional team.
Welcome to episode 50 of the No Stroke Podcast. My name's Dave Dansereau. I'm here with my co-host, Mike Garrow. Mike, congratulations. We made it 5-0.
Congratulations, David. It's a milestone I've been looking forward to. I know we both have, and I think today was an excellent way to hit number 50. A fantastic guest.
Yeah, absolutely. Yeah, it's been real fun doing this. It's as we're not going to lie, it's a lot of work, right? But we started this about almost coming up in May will be 2 years. 2 years and 50 episodes between our day jobs, right? Not a bad pace.
Yeah.
So
I'm happy with it. It's certainly going to be pushing for the next 50 here. We'll see if it takes another 2 years. I mean, we've been on a better pace here the last few months.
Yeah. I mean, it's you go with when you can book your guests, and you go with when we're available, and that's sometimes morning. We have another one tomorrow morning, but we're laying down the intro here, and let's get into it. First, in the news here in Boston today, we can't be remiss not to mention the Boston Marathon. Didn't catch too much of it. I was working, but great day to have one run with overcast 50-degree weather. It was a fast race for both the men's, women's, and wheelchair races. Really went off really quick today. So
yeah, big day for you, going back to your marathon accomplishment after your stroke.
Yeah. I looked at the weather and I said, oh boy, not another one of these, because I still wake up sometime on Marathon Monday and see the rain and the but it held off for the most part. And as you see, for our YouTubers, I am wearing there we go. I got the unicorn, the Boston BAA logo in memory of today's
nice
all the folks. And I also thought of all the folks that, thinking back to Tim Whitmer's episode, and I still got to do another soundbite for that because it resonates for me when he says a down payment on your day, referring to exercise. So there's a lot of runners in Boston did a lot of down payment to make this day happen, and it looks like it paid off for many of them. So that's kind of.
I have a quick one though. In the spirit of our 50th episode, and as you were saying, it's a lot of time that we put into this, right? And it's often hard to, other than looking at our download metrics and, the comments that we get on a LinkedIn or Twitter post, it's kind of hard to, get feedback and see the real value of what we're doing, right? And I just want to share two things, that really resonates, as we kind of eclipse this 50th episode milestone here. One, I had the opportunity to speak to a stroke support group out of Connecticut called Stroke OT. Shared a lot of our past episodes, but just being able to kind of be in the room with folks who are really looking for this information, so being able to see firsthand kind of the reactions to some of the sound bites that I shared with them, and the need for us to continue doing this. I think that's really what resonated coming out of that presentation was, the excitement, the questions that really came from some of the sound bites as well. And as I put that together, we have such a broad range of past episodes here, really covering the spectrum of, we're fortunate to kind of have Kyle and his mother come on recently. Kyle spoke to the impacts of pediatric stroke. We've had, clinical thought leaders like Pam Duncan, who are really trying to move the needle in this transition to care space. And then, bright minds like Arun from Shirley Ryan, as well as Dr. David from Mount Sinai. And there's just, there's a reason that you and I know the reason we're doing this, but it's nice to get that reassurance from folks, who are out there in the real world, and trying to answer some of these questions and really looking for hope and optimism, and I think that's what we're able to provide. And then secondly, I had, and as it kind of alludes to today's discussion with Dr. Richards, I had a colleague of mine actually reach out, and I've shared some of our, I'm connected with a lot of folks on LinkedIn, and that I work with, and when I repost things that we've done from sound bites with the podcast, people are aware of my work outside of CVS, but I had a conversation with someone recently, again, a colleague who mentioned that she listened to one of our recent podcasts where we spoke to, I believe it was the episode with Kyle, actually, and talking through pediatric stroke. And she was just like, wow, I had no idea, stroke could happen at such a young age. And, she had some underlying health issues. So she, kind of took the time to research a bit more and learn the symptoms of stroke, which, again, as we'll point out to here, be fast, right? So being able to recognize these symptoms. She ultimately had an incident a couple of weeks back where thought she was having a stroke, and she said, you know what, Mike, if it wasn't for the podcast that I listened to and took the time to kind of learn about stroke more, like I possibly would have just put it off and not reached out to a to emergency doctor and go to the ER for a quick check. Thank goodness, it wasn't a stroke, but again, it was our platform, our ability to kind of share this message, that empowered her to go look and learn the symptoms. So, again, I think it's what we do here. It's important stuff, and I'm really happy to kind of, over the last couple of weeks, seen some of this feedback and reassurance of what we're doing is right, and we need to continue to do 50 more and 50 more and keep it going.
Yeah, thanks for sharing both of those. And I know, like, you were out and doing your presentation, and that deck you put together, really, we move through a lot of these episodes so quickly, and then we move on to the next one, that a lot of times bringing those highlighted in those sound bites to the surface. Because every time I leave an episode, I'm reminded of a great line that we often refer back to often on, as we move forward on some of these episodes, but also some of the content, like when someone does give you that feedback, you're like, wow, that was perfect timing, and we need more than that. And to not, in this episode that we're going to presenting today is no exception, because Dr. Chris Richards had some phenomenal takeaways from the perspective of an emergency physician and a first responder. And he goes over the 8 steps in the chain of survival, and things that I think our listeners are really gonna benefit from. So do you want to give a little bit more intro, as you made the connection here with Dr. Richards?
Yeah, definitely. So we spoke with Dr. Ava Mistry from University of Cincinnati Health System a couple episodes back. And from there, we've been fortunate to be partnered in with the stroke team at UC Health. And they really saw, what this platform could provide, to share some of the work that they're doing. So we're happy to kind of bring on a second guest here from UC Health, Dr. Christopher Richards. So he is the medical director for the UC Health Mobile Stroke Unit and assistant professor in the Department of Emergency Medicine at the University of Cincinnati College of Medicine. Dr. Richards, he did his residency at Northwestern in Chicago and had a fellowship in the Chicago area within emergency medical services. So EMS, those are the folks, who are arriving, the first responders, paramedics, EMTs, who are either affiliated with a, ambulance service or embedded into a local fire department, things like that. But what was really unique with his perspective and his background is, he understood that lens of a first responder, and go to in the episode here. It's so vital at at the acute stage of identification of a stroke, right? And then as we discuss here today, the need for the dispatchers to know that this is a stroke, right? Because what we really dive into today are all about mobile stroke units. But we have a pretty in-depth conversation kind of at that initial phase of, when if your region, if you're lucky enough to have a mobile stroke unit within your area, how do you make sure if you're having a stroke, you get one of those, right? And
Yeah.
it really goes down to, what we discussed today around, and, what we discussed earlier as well with one of my colleagues who, understood these symptoms of identifying a stroke, right? So again, you've probably heard of the acronym FAST, right? So face droop, arm weakness, speech difficulty, and then time, right? So they're also now, kind of saying to add be fast, right? So instead of just fast, you also want to be looking out for balance loss, which could be a unique identifier, as well as eyesight changes, right? So you're having blurred kind of differentiated vision. Those are all, signs of stroke. And what's interesting about today's discussion, ultimately, when someone calls 911, when you kind of, as a fuck to, going back on a call center, recordings, listening to what people are calling into when it is a stroke, oftentimes they're not saying my loved one or I am having a stroke, right? And it's so important if you have a family member with the past history, or if you know these symptoms, right, to really make sure you're saying, I think I think my friend, my loved one, this stranger is having a stroke. Because that is going to be, there's ways that the dispatcher could maybe identify that, but even if you think, right, say that, because that is then kind of triggering everything in the back end. For, again, if you're lucky enough to have a mobile stroke unit in your area, to be dispatched and sent to the scene. And UC Health, they're one of the first in the country to have this mobile stroke unit. They first launched in August of 2020. They're partnered in with about 15 fire EMS departments across Greater Cincinnati. And, to date, they've had hundreds of patients can benefit from this mobile stroke team. It's just a really interesting service. They have these stroke units outfitted with a number of tools, including a CT scanner, clot busting medication, and an iPad that could actually do a consultation with a stroke neurologist right within the ambulance. So we've covered mobile stroke units in previous episodes. Obviously, the guys out in Australia who are now bringing this technology into the air, and just because of the how rural it is across Australia. But today we really deep dive within that acute phase, the identification and kind of what that service integration looks like for mobile stroke units, not only in Cincinnati, but Dr. Richards is a thought leader for integration of these mobile stroke units at a national and international level. So we'll get some perspective from him on the challenges as well as benefits to having this be a standard of care for the stroke continuum.
Yep. Perfect, Mike. Well said. Thank you for setting up that intro. And this is going to be a great episode on our Big 5-0 for the No Stroke podcast. So enjoy this one, folks.
Hi, and welcome to the No Stroke podcast, Dr. Richards. Great to have you here.
Oh, thanks for having me. I appreciate it.
For sure. So, you're a colleague of one of our past guests, Dr. Ava Mistry, who was on recently. She spoke to some brilliant research being done at University of Cincinnati Health, and we then got connected in with you because of your really trailblazing work within this area of mobile stroke units. And as we know, and many of our past guests have said, time is brain, right? And this service of mobile, bringing imaging into an ambulance and getting people to the hospital sooner is such an important aspect of stroke care. And the work that you have done really exemplifies some of the outcomes. So we're really excited to have this conversation with you today. But for our listeners, can you give a bit of background kind of in your career to date and what's led you to your role?
Yeah, I've had an interesting pathway. It's been fun for me, but I'm an emergency medicine doc. So my training is in emergency medicine. During residency, I always had an interest in pre-hospital care. It stemmed from when I was an EMT basic in college, and I always really maintained the interest in that pre-hospital space. After graduating from residency, emergency medicine residency, I did an EMS fellowship. So I'm also a board certified EMS physician, which means that I provide care in the out-of-hospital setting. I'm an EMS medical director for a number of fire and EMS agencies, initially when I was in Chicago and now here in Southwest Ohio. And I also, as part of my background, really wanted to bring a structured research approach to what we do in the pre-hospital care space. So I, after residency, did a structured research fellowship in health services research, got a master's degree. Through that, my focus was on acute stroke. I also extended that to StrokeNet, which is a national stroke research network. So through those mechanisms, I was really supported in developing this niche in pre-hospital stroke care. Initially, I came to it through kind of a systems of care approach. And really that is a lot of kind of where my continued interest and passion lies, is how do you construct a system of care to best affect an outcome? But obviously the intersection of the acute treatment lends itself really well to what we're talking a lot today about, which is the mobile stroke unit, because it really is a way to bring, and this is what I usually tell folks, is to bring the emergency department to the patient's curbside, where we can provide that acute evaluation and usual treatment for patients with acute stroke. So when I moved from Chicago here to Cincinnati about 4 years ago now, it was really a great opportunity in terms of mentorship focus of the stroke team here in Cincinnati. It was right around the time that the mobile stroke unit was coming online. And so it's really been a nice way to kind of blend all the interests in pre-hospital care, acute stroke care. And now I actually am a clinical faculty with our stroke team. And so I do take calls. So when any of our partner hospitals have an acute stroke, they give us a call and we kind of talk about either thrombolysis or thrombectomy, the two ways to treat ischemic stroke.
So perfect. That's a great intro. And before we dive into the topic around today's discussion on mobile stroke units, I'm always curious, you tell us, in the fast-paced work that you do, what do you like to do to unwind? How do you control your own blood pressure?
Yeah, I know. That's a great question, right? The one of the nice things about emergency medicine is shift work, right? And so when we're there, it's very much on, but at the end of the shift, we're able to, provide for continuity of our patients or our colleagues who are coming on, and we're able to kind of shut off. So I honestly love just kind of hanging out. I have two boys who keep us really busy. They're big into swim team these days, and so it's a lot of evenings over at the pool and kind of relaxing as best we can. We've started, fortunately now, we feel a little bit more comfortable traveling, and so we've been able to take the boys on some trips now, and just enjoying what we can, right?
Love it. And the background with EMS, I respect so much. My father ran a EMS service here in Connecticut for about 20 years. So I mean, it's the way, you really get to the root cause of so many of these issues, right? And you're that first responder. And it's a super impactful role to now kind of, with your interest around how we improve these, continuums of care, specifically within stroke, like that first response is such a critical part, and it kind of leads into what we'll kind of dive into here. So I think with your background, like, give us a lay of the land, like what makes the region within Cincinnati that UC Health has that management over unique in terms of stroke care, right? Because we always say, no matter where in the world you have your stroke, it's a stroke, right? And again, every stroke's a little different, but it's that place that you are when you have that stroke that ultimately impacts so much of, what your outcomes might look like. So let's get a sense of kind of what Cincinnati, what's that made of? Like how is it unique?
Yeah, it's, south in the greater Cincinnati. So Southwest Ohio, Southeast Indiana, Northern Kentucky really has a unique asset in the UC stroke team. So the way that acute stroke works, and there's about 25 or so hospitals in the general area. There are 2 comprehensive stroke centers, 2 thrombectomy capable stroke centers. And the rest are primary stroke centers, acute stroke ready hospitals. Some don't have a level of certification, especially some of our even further out hospitals. But they all have the UC stroke team as a resource. And that has really been historical in its origin. So back when TPA was being studied, Dr. Joe Broderick, who really is kind of one of the legends in the field, he's still an active clinical member of our stroke team. Dr. Art Pancioli, my chairman, who's in emergency medicine, this core group really came together to help make that decision whether to give TPA or not. And it was really for the entire region. It was all the health systems in our region. We have, probably 4 or 5 major health systems in the region. But when it comes to acute stroke care and that decision about acute reperfusion, so TPA or endovascular, it ends up being a very actually synergistic approach. So I did mention I take call, and what we do is we're on 24/7 call. If a patient with an acute stroke comes in, they activate their stroke code process, which just kind of gets everything moving. It gets the CAT scan cleared. It gets us called so we can have that conversation with the emergency physician and talk about whether the patient is eligible for thrombolysis or not. Obviously, we have the capability to talk with the patients through an audiovisual connection as well. So we do a fair amount of telestroke. And then we work with 2 different groups of endovascular specialists who, if the patient has a large vessel occlusion or something that needs to go kind of right now for that minimally invasive procedure to get that clot taken out, we're able to coordinate with them and really work with that hospital, wherever they are, to end up at the highest level of care that is best for that patient.
That's really interesting. And you and your team, were you really at the forefront? Is there were you one of the first groups in the country to lead the way with these mobile stroke units?
Indeed. So the initial NINDS study was University of Cincinnati. Dr. Broderick, Dr. Pancioli were really key influential principal investigators on that study. And so it is kind of fun to hear the history of the UC stroke team in the context of really the development of a specialty when it comes to acute stroke care and acute reperfusion. They at the time, and actually almost up until the time of COVID, the person on call for the UC stroke team would physically drive to all of our hospitals in the area, have a face-to-face interaction, and seeing the pictures of the receipts from the cell phone bills of those huge box phones from the early 2000s of the initial stroke team members is really kind of impressive, and thinking about all the history that's behind this treatment and how far we've even come in that period of time. Now we do a lot of, and in fact, I think most of my partners do almost exclusively telemedicine. It's been such an important advancement in being able to really widely provide the service that we're able to provide. And obviously COVID kind of accelerated that in terms of having these conversations. But the history in Cincinnati with TPA is rich, and it's been fun to join the faculty and be a part of it now.
That's great. And, being leaders in the space, right, and kind of pushing the way with some of these initial research papers that really proved the efficacy of it. It also went into the service design of this, right? And I think something, that I saw, which is a bit unique, well, to some degree, but like, can you speak to the actual care team that is involved within this stroke unit, and like, again, how that might be a little different in different, like, other areas that have this service?
Mm-hmm. So when it comes to the mobile stroke unit itself, it is a fully licensed, fully stocked critical care ambulance. So if you were to call 911, an ambulance shows up. For most people in most places, that ambulance is what's called ALS. It just means that there's paramedics who can do advanced medications and skills when they're there at the curbside. So it has all that equipment. The addition, of course, with the mobile stroke unit brings is a CAT scan. So it literally has a CT scanner in the back of the ambulance that we're able to image at least the brain. And basically all mobile stroke units have the capability to go to the top of the neck. There are a couple programs out there that can go all the way kind of to the upper chest to look at all the neck vessels. But at a minimum, we can all do the brain. And we can talk about why that is. We also have the ability to give thrombolysis, so that clot busting medication, either TPA or tenecteplase, and have that communication in some way with a stroke team member. So a lot of mobile stroke units use a remote telestroke platform to have that communication. Some places actually have the stroke team member, the stroke neurologist, or even in some places, an advanced nurse practitioner riding along in the ambulance, the mobile stroke unit ambulance, to go out on these runs. It's a little bit of a kind of system by system decision in terms of how that's all staffed, but suffice to say, the critical components of what you need to do in that first half hour are really brought to that curbside. So in addition to the imaging capabilities, the medications, we logistically have a nurse, a paramedic, an EMT who operates the vehicle, and then a CT technologist who operates the CAT scan. And then, of course, our remote rider, our stroke team member.
Well, so if we could back up a little bit, and I think this goes to, your background, having boots on the ground within, with your experience within EMS and kind of doing rides as a EMT and seeing this first instance, right? Because so much emphasis goes around stroke awareness, right? So actually knowing that you might be having a stroke, or your loved one knowing these symptoms, right? What is done, and I don't know if you have this data of like, folks who have a stroke, who end up being positive for having a stroke versus like what was recognized by dispatch as a stroke, where now these mobile stroke units are going to the unit house. Like, is that still an area that needs to be improved, and like what might need to happen to have that indication be a bit higher?
Yeah, that's a great question, and if you'll indulge me, I'll kind of answer it a bit long-winded. But sometimes, there's a concept in kind of the very acute phase of stroke care called the stroke chain of survival. Your listeners probably have heard about it, but it's a concept of what are the key steps that need to happen from the time that a patient actually experiences the stroke to the time when they're actually admitted to a stroke unit. And half of that, so there's 8 steps, but half of them occur before the patient's ever in the hospital. And the way I frame it when I have conversations with our paramedic partners or MSU, and then even sometimes talking to community members, is that chain of survival is only as strong as its weakest link. So if a person maybe is experiencing stroke themselves, more often than not, their family members notice that something is wrong and they don't call on 911, well, that's an opportunity missed potentially. If the dispatchers, if the paramedics, if don't recognize stroke, then things can get delayed. If there's not effective communications to the emergency departments in advance, that's another opportunity. So it really all kind of comes together. And what I'll say is the American Heart Association, American Stroke Association does a really good job at messaging to the community about signs of stroke, right? So it's fast, facial droop, arm weakness, speech difficulty. Increasingly, we're trying to message out about acute vertigo, so dizziness, balance issues. If there's any eye problems, these are all potential signs of stroke. That said, not all strokes read the textbook, and so sometimes certain types of stroke, especially the type that is what we call the posterior circulation, so when it goes to like the balance center of the brain, or if it's a hemorrhagic stroke, so a bleeding type of stroke, sometimes patients with those types of strokes only have decreased mental status. They're confused. Certain types can give you a really bad headache. And so the screening that we do is sometimes somewhat limited to a certain subclass of stroke. When we do education with our paramedic partners, we, of course, highlight the classic symptoms that FAST and others identify, but we talk about these less typical stroke syndromes. And we also talk about it in the context of atypical patient populations, because there are certainly some folks that are probably more likely to have atypical symptoms when they have a stroke. We oftentimes don't think about the 35-year-old woman of having a lot of stroke risk factors, but that is a certain population that does not necessarily have typical stroke symptoms, but has a higher risk of being missed, largely because of what we just talked about. So messaging about the ways that stroke can present is critically important, not only for laypersons, for the 911 dispatchers, for our paramedics. We actually looked at, when I was back in Chicago, we looked at, we actually listened to actual 911 calls for people who had confirmed stroke. They were diagnosed on an MRI or CAT scan with stroke, and listened to what was the content being expressed in that 911 call to the 911 dispatcher. And I will tell you, a lot of the time, we're talking about half the time or so, folks use kind of vague or imprecise language to describe what's going on. Either that, or they say, you know what, I think that a stroke or a heart attack or something like that is going on. And so that is totally reasonable for someone who doesn't have a medical background to use those kind of words. I'll kind of bring back the curtain just a little bit to say that for a 911 dispatcher who's hearing words like that, for them to alert the paramedic who's coming on scene that, this person is having a stroke versus, they're having a heart attack, are actually very divergent pathways in advance of that paramedic coming. But if we think that if we're able to give that pre-arrival information to the paramedics to kind of cue them that, hey, this is probably a stroke going on, that they're more likely to recognize stroke, spend less time on the scene, get them directly to a stroke center on the back end. Now, what I sometimes do, and I'll take this opportunity for your listeners, is that, and particularly your listenership is very attuned to stroke. I would empower them to use words like that when they are having a conversation during the 911 call. Say, you know what? I think that my loved one is having a stroke. What we found when we listened to these calls in Chicago is that when callers did that, when they said, they actually used the word specifically stroke, there was a much higher chance of the paramedics were going to get dispatched out of the suspected stroke. That makes sense on the face of it, but the reality is that was not happening in most of these calls.
I'm so glad you described that in such detail to convey that to our listeners, because the language, I guess the follow up question I have to that is how important early in that conversation, the caregiver, the loved one who's making that call, to perhaps mention, I think my husband or wife is having a stroke. They've had one in the past. Like this is not the first event. If that's the case, how quickly should they bring that up in the conversation? Should that be the second thought that they get across the line?
Yeah, that's a great question. And maybe I'll kind of bring through a little bit of kind of the anatomy of a 911 call. But so when if you haven't already, when you call 911, you'll get patched through to an emergency medical dispatcher, an emergency telecommunicator, whose first job is to figure out where you're calling from. So they're not meant to be rude or anything like that, but they want to say, all right, what's the nature of your emergency? You give a really quick line and they say, all right, tell me your address. Because what they're doing in the background is they're trying to figure out where is the closest ambulance. Maybe it's a fire engine or something like that with a paramedic on it. And they'll actually take about a minute or so to get that information nailed down. After that, they'll say, all right, so tell me a little bit what's going on. And that's the opportunity to say, I think that my mom is having a stroke. And it cues that 911 dispatcher to bring up all the information that they need to ask a little bit more follow-up questions and kind of refine that down so they're able to give that information back. Now, once it kind of hits a point where the dispatcher has enough information, they'll actually start dispatching out the paramedics. The 911 telecommunicator is still going to be on the phone talking to the caller while things are already moving in the background. Sometimes that's hard for us to kind of conceptualize. Like this is an acute emergency. I want the medics there now. Why are they asking me all these questions? The reality is they're trying to get as much information for those paramedics in advance while they're already actually getting there on the road. So to more directly answer your question, upfront, as soon as possible, use the word stroke.
That's great. And I'm sorry if I missed it, but like what were some of those descriptions on the calls that didn't say I had a stroke? What exactly? It was like, I'm feeling funny. Like what were some of the adjectives used?
Yeah, it was stuff like that. It's like, my mom, she's just not acting right, or she's not feeling well, or sometimes actually it would use, the callers would use words that maybe they were a little bit more familiar in describing, or describe things that were more related to past medical conditions other than stroke. So, my mom has a history of asthma, something's going on with her, or, my dad is vomiting and something is wrong, if it's like a posterior circulation stroke where they have an acute vertigo. So while of course you use words that are key in describing what you see in front of you during that call, I'm not asking anyone to be a diagnostician and to have a crystal ball about what's going on. If you don't know what's going on, then you describe what you see. But like I said, if you are like, oh, this is what happened when they had their stroke two years ago, and I'm worried it's happening again, that information can really help that interaction.
Yeah. It just has my mind as like, a bit of a nerd around like big data and like voice recognition technology, right? Like that seems like a great opportunity, right? Like how do we analyze some of that and help predict, what might be a stroke, right? Yeah. Interesting. There, you see health researchers, there could be a great opportunity.
Well,
is it happening? Or is it happening?
You are spot on. We are thinking along the same line. So actually, I'm realizing I didn't actually address one of your earlier questions. I actually, through the University of Cincinnati, have a pilot grant to look at a large national data set that mixes EMS, electronic medical records, and hospital medical records. For the first time, actually, to understand how often dispatchers, paramedics, and the eventual diagnosis of stroke are all aligned. We first need to describe that before we start launching into further studies, which is kind of what you're describing, which is how do we basically help assist that conversation so we have a higher fidelity at that point of the 911 call. It's helpful not only in EMS systems with mobile stroke units, that has been clearly identified, but in any EMS system, to cue responding paramedics to the presence of strokes, we think is of utmost importance.
Yeah, this is great. We're going to continue this conversation after a quick break here, and we'll be back with Dr. Chris Richards.
All right, and we're back here with Dr. Richards from UC Health, in Cincinnati. Gave us a great, background here of, the history and the rich history really within Cincinnati's stroke region to improve thrombectomy rates and really, be the ground, really be some of the first trailblazers with this mobile stroke unit service. And I love the deep dive that we covered within that acute phase, with it from a dispatch set point of view, and really the importance of survive, whether you think you suspect someone having a stroke, really just spell that out, right? Know the symptoms, and then really to what you described, right? It's vital that, you share that with the dispatcher, whether it's prior health history, to get that ball moving for a mobile stroke unit. So I want to transition now to discuss some of the work that you're doing at a national level, really to look at how we implement these units in other regions across the US. There's mobile stroke. I'm based in New York City, in a multitude of different, hospitals, New York Presbyterian, Mount Sinai, they have these stroke support or mobile stroke units. But, what is going on behind the scenes to think about, standardization and kind of getting these, again, as a point within the stroke continuum of care, that this is just a normal thing, right? How far are we off that?
Yeah, that's a great question. So we are still pretty early in terms of our experience with mobile stroke units. So here in the United States, well, let me take a step back. So internationally, Germany was really the first to kind of launch this on a scale that we've talked about. Here in the United States, Houston, Cleveland, Memphis were some of the very first ones to kind of break the ice when it comes to the mobile stroke unit paradigm. And since they've done that, we have more and more information. And in fact, we even have 2 clinical trials now about patient-level outcomes for patients with acute ischemic stroke who are treated in mobile stroke units. And that actually was a huge part of the understanding and the explosion behind the support for mobile stroke units. So before then, we kind of relied on the experience of kind of the trailblazing mobile stroke units to say, boy, we can get thrombolysis to a patient about a half hour earlier just by having the mobile stroke unit there, even in highly functioning EMS systems. That's because you just cut out the logistics of that transport. Like I said earlier, you bring the emergency department essentially to the curbside. You're able to do things like have a half-hour time savings. And when time is brain, then that potentially makes a huge difference. So early on, we had that experience with 2 clinical trials, one of which was called Be Proud, which is out of Germany, and Best MSU, which was a US study. Most patients enrolled out of Houston, showed that patients treated with thrombolysis, it was mostly TPA, in a mobile stroke unit had significantly better clinical outcomes than those who had conventional treatment. Probably a really important reason for that is that patients in that setting, in the mobile stroke unit setting, were getting TPA in the first hour, the first 60 minutes of stroke onset or last known normal, at a much, much higher rate than patients who need to be transported. And that makes sense. If we're given the TPA a half hour earlier, then, and everything else is really working as it should, people are calling 911 right away, then we're able to facilitate that. And in fact, in Best MSU, it was about a third of patients who were getting TPA within that first 60 minutes compared to a single digit. I think it was about 5% or so in usual care. So now that we have really convincing clinical data around this question, the next question, which we're starting to delve into as a field, which is gaining in kind of maturity and understanding, is where does the cost effectiveness balance lie with mobile stroke units? So it's not an inexpensive endeavor to outfit an ambulance with a CAT scanner and stock it with thrombolysis, TPA, and I didn't even mention, but actually we're able to reverse certain types of hemorrhagic stroke if someone's on a blood thinner. We carry those medications too. So it's not an inexpensive endeavor. But what we've learned from the research groups that I just mentioned is that, especially for patients who are really highly functioning physically, mentally before their stroke, if they receive the TPA, the treatment in this setting is quite cost effective, and getting that understanding in addition to just the clinical benefits is really important. Now, at the same time, when we think about implementing where to have a mobile stroke unit, I think it's also important to understand the resources that are in any given community. So like I said, I came from Chicago, and there is a mobile stroke unit kind of on the near west side, and then in the west side suburbs of Chicago. But right downtown, there are a lot of primary and comprehensive stroke centers. And so not to say that that's not a great location for a mobile stroke unit, but you have to wonder, what is the additional time savings that a mobile stroke unit can bring when they're on scene with those patients, which is longer than our usual EMS scene times, but is probably time well spent. And that's kind of what we have to think about when we construct a system like this is this time well spent for those patients who go into the mobile stroke unit?
And that's a really good point you bring up in terms of cost effectiveness, because it's really utilization of services over time too. And if you're reversing some of those early deficits, and as a background in physical therapy, that can be a long journey for rehab, both speech, OT, and utilization for years down the road. That early intervention could have a big part in minimizing the need for those services. So that's really an important point to bring up.
Yeah, and in fact, actually, the folks out of Houston, when they looked at kind of their national data set, actually, it is more likely for a patient who's treated in a mobile stroke unit after their initial hospitalization to be discharged to inpatient rehab, but that gets translated into more days home over time. And so I think your point about what is the longer term outcomes of these patients is so important to highlight. Now we actually have that information.
That's great. And now it's kind of that next phase of bringing this to payers to say, right, like, we are improving these long-term outcomes. And if there's there's a lot of integration now with value-based care contracts being rolled out as opposed to fee for service. And like, how could those mobile stroke, granted, we're not checking your insurance to see if you get a mobile stroke unit or not, so I think that's kind of a barrier when you think of a health system like we have here versus, a universal health system like, NHS or what might be in other places in the world. But yeah, it's a challenge, but I mean, the work you're doing is important. Like, are there any of these discussions with CMS and things to try to see some reimbursement for this, or what's the path for that?
Yeah, this is such an important question. So right now, the way that most mobile stroke units are set up to reimburse all this great care that they provide is actually within the context of what CMS already has set up for ambulance transports. And so it's not to get too much in the weeds, but essentially it's what's called ALS2, which means that all this, the CT scan, the potentially the TPA, the critical care nurse, all that, because it's in the context of an ambulance care, there is no reimbursement model right now for all that complexity of care. And so it kind of defaults to what is already on the books, which is essentially to reimburse for a standard ALS paramedic transport, which especially when you're thinking about TPA administration in the field, or tenecteplase, now that some of us are moving in that direction, because of medications given in the pre-hospital setting, it can't be billed separately. Everything that's done in the pre-hospital setting, regardless, again, of kind of what's going on, is bundled into that ALS treatment. Now, there's a little bit of kind of back end, so that there is a professional fee if you see the neurologist on telestroke and the read for the CAT scan. But the reality is that is kind of how the mobile stroke unit program will get reimbursed for the services provided. Now, there is certainly advocacy, and like I said, especially now that we know the really dramatic positive impacts that we have for our patients, it does give more emphasis and oomph when these conversations are had. And so we've had conversations locally and statewide. An international organization called Presto, which is the Pre-Hospital Stroke Treatment Organization. It's really kind of an organization to support mobile stroke unit programs. They've done a ton of advocacy. Dr. Jim Grada out of Houston is really a key advocate in this context here in the States, and of course a number in that organization. And so, the community of us, we advocate, every chance we get, but a lot of it really is based on this is such a unique thing that kind of the infrastructure to acknowledge it just kind of hasn't caught up. And so we're trying to kind of spread the good word about that.
Great. And, before we move into our last question here on the magic wand, there's obviously still a lot of work to be done within mobile stroke units on the roads, right? When you're in, and I had pulled Google Maps up here, when you're in East Fork State Park in Bethel, Ohio, and you have a suspected stroke, right? Are we going to get to the point, that we have these mobile stroke units in the air as well?
Oh, that's a really good question. And I will say that Bethel is very nice. That's a nice drive. I actually did my emergency vehicle operating with the Bethel Tate Fire Department, and so they kind of refreshed my ability to drive lights and sirens in my EMS job. But it's a really important question. Again, it kind of gets back to where are mobile stroke units best deployed. And if I had to guess, it's probably a little bit of is the porridge too hot or is it too cold? It has to be kind of just right. It's sometimes in a very rural location, while clearly the benefit of a mobile stroke unit is there, you have to think about what is the potential frequency. I think it's a really interesting conversation, and folks are starting to consider this. In fact, I think there was a recent article that just came out about equipping air ambulances with that capability, and I think it would be cool. It all does come back down to a couple things, which is again that recognition, both by the patient, their family, that interaction with the local paramedics, and then what is kind of the balance of time for that patient, right? So if it happens that the patient who's experiencing stroke can go to an acute stroke ready hospital, get a CAT scan and thrombolysis faster than the air ambulance can get out there with the same equipment, well, then maybe the question's one that you just end up going to that local hospital. If it's a situation where their routine for severe stroke patients is to call an air ambulance, and then you have, an hour flight back to the mothership where they're getting their CAT scan. Well, then I think we're having a different conversation, right? I think some of this actually does come back to the interaction and the relationships that mobile stroke units have with their local EMS partners. I think it would be particularly heightened in a scenario like you said, where you're having a secondary request. But I'll tell you, even in our area, our mobile stroke unit is actually quartered at one of a suburban fire department. Is at Springfield Township, and a lot of that was based on the advocacy that they had. Their recently retired chief, Robert Leininger, who was a really strong proponent, and to have that him and the EMS community as strong allies just makes all the difference, especially in a model like what you're describing, where you might have the paramedics secondarily requesting the mobile stroke unit to be dispatched to the scene.
That's very very helpful to hear that too. The logistics, never thought of that angle, where it's deployed and how much time and the whole process of connecting the dots there. This has been phenomenal. I'm so excited for our audience to hear this, because it's not often you get to hear that first responders point of view and behind the scenes. I really feel like you're giving our audience some great information within this episode. But we are at the point where we come to the conclusion here with our magic wand question. As we wrap up this episode, we end with this question, which is, if we were to hand you a magic wand, how would you redesign the stroke care pathway?
So we have a saying in EMS, which is the right care for the right patient at the right time. And I think if there is any way for us to just strengthen that stroke chain of survival, understanding that at least in our current system, there's going to be kind of overactivations, there's going to be atypical presentations, to have a greater awareness of stroke all the way down that chain of survival, I think really does give patients with both ischemic strokes and hemorrhagic strokes the best chance of prompt recognition, prompt treatment. Now, there are actually futuristic ways of moving diagnosis into the field so we can get better at that. There are certain companies, and I don't have any ties or disclosures, but there's certain ones that you can put things on the head almost like a helmet to get a sense of, oh my gosh, like this might actually be a large vessel blockage, this might be a hemorrhagic stroke. All the way down to making sure that emergency departments recognize and continue to reinforce their processes of care that help facilitate a CAT scan so we can have a diagnosis, to talk to a stroke specialist. And then also then on the back end, if it is an acute stroke ready hospital, if it's a critical access hospital, even a primary stroke center, if the patient has a severe stroke and they need to be transferred, how do we best optimize that? And that ends up getting kind of tricky, because boy, if you can know in advance as much as you can, you start getting an ambulance ready to make that interfacility transport, or maybe the helicopter if the distance is such. But having the maybe redundant resources to facilitate that for those patients, I think that's a really important next step for really the most severe strokes that patients experience.
Thank you for that. Really well said. And, like David was reiterating, before the magic wand question there, the insights provided here, at that acute stage, it's super valuable stuff. And, again, an episode like many that we've had like that, it just opens your eyes to different perspectives, right? So it's just amazing to be able to have these conversations and share them, with folks across the world. So thank you for your time today. It's been a really, really nice chat with you. Hope to maybe get you back on when you go sift through that big data set and we start thinking about a research
I'd love
proposal. Yeah, well, we'll certainly be in touch.
Well, thank you for having me. This is awesome. Great conversation. And thanks again. I love to come back again.
Absolutely. All right. Thank you.
Absolutely.
Take care now.
Thank you.